Good morning. First of all, let me thank the scientific committee for having me discussing these interesting abstracts on future therapeutic strategies in HR-positive breast cancer. Here are my disclosures. So these abstracts may be divided into groups. The first focusing on the inhibition of PI3K pathway, and the second in the optimization of endocrine therapy in early breast cancer. Let's start with the results from the cohort C of BELIEVE, presented by Dr. Rugo and colleagues. So this cohort enrolled patients with PIK3CA mutated, HR-positive, HER2-negative advanced breast cancer, whose disease had progressed on prior aromatase inhibitor and who had received chemotherapy or endocrine therapy as immediate prior treatment. Prior CDK4/6 inhibitors were not mandatory in this cohort, in contrast to cohort A and cohort B. Median number of lines for metastatic breast cancer was 2. 46% of patients had received prior chemotherapy for advanced disease. Only 2/3 of patients received prior CDK4/6 inhibitors, and 23% received prior fulvestrant together with CDK4/6 inhibitors. Cohort C of BELIEVE met its primary endpoint. PFS rate at 6 months was 48.7%, with the lower boundary of the confidence interval exceeding 30%. Median PFS was 5.6 months, and it was slightly longer in patients receiving endocrine agents as last line of therapy. In an exploratory biomarker analysis using ctDNA, authors found that patients with a ctDNA fraction of less than 10% had strikingly longer median PFS than patients with ctDNA fractions higher than 10%, 16.7 versus 5.4 months. In contrast, no differences were observed in PFS between patients with or without ESR1 mutations detected in ctDNA. Perhaps we can discuss later on a little bit more on the method used for ctDNA detection and also for the choice of the cutoff. If confirmed, this in other cohorts of BELIEVE or in other data sets like SOLAR-1, we should also discuss what are the implications of these findings for our clinical practice. Most common adverse events were hyperglycemia, diarrhea, nausea, rash, and fatigue. Grade 3 hyperglycemia occurred in 23% of patients and led to dose interruption or adjustment in 25% of them. So as this drug is more widely used, I wonder if we can further improve the rates of hyperglycemia, and we may also discuss hyperglycemia management in our practice, especially the number and type of drugs that are generally used and were generally used here. As in cohort B, the use of prophylactic antihistamines reduced the severity, but not the incidence of rash. From a clinical practice perspective, I wonder whether we should use some additional prophylactic therapy for rash beyond antihistamines. So this table summarizes the results from the 3 cohorts of BELIEVE and also the alpelisib plus fulvestrant arm in SOLAR-1. Please note that cohort C of BELIEVE enrolled a more heterogeneous and more heavily pretreated population, but nonetheless, efficacy of alpelisib and fulvestrant is very consistent across all the arms. So with this in mind, my final question to the authors is whether you think that BELIEVE supports the use of alpelisib plus endocrine therapy in all patients with PIK3CA mutated, HR-positive, HER2-negative advanced breast cancer, regardless of prior treatment. And if so, what are the implications of the BELIEVE trial for regulatory authorities? So the second abstract from Dr. Lehman and colleagues present the results of a phase 1b expansion study of gedatolisib, a pan-PI3K/mTOR dual inhibitor given intravenously in combination with palbociclib and endocrine therapy in women with ER-positive advanced breast cancer. After dose escalation, study had expansion with 4 arms. Arm A for patients treated in first line with palbociclib, letrozole, and gedatolisib. Arm B for patients with no prior exposure to CDK4/6 inhibitors treated in second line or posterior lines with palbociclib, fulvestrant, and gedatolisib. And arm C and D for patients with prior exposure to CDK4/6 inhibitors that were given in second and third line treatment with palbociclib, fulvestrant, and gedatolisib. Now, please note that the differences between arm C and D was the schedule of gedatolisib. In arm C, it was given weekly, and in arm D, it was given 3 out of 4 weeks. 103 patients were included in this extension. And although enrolled in the same context, please note that patients enrolled in arm C were more pre-treated than those in arm D. Almost all received prior chemotherapy compared to 60% in arm D. And this is important to keep in mind when looking at the efficacy results. But let's start with tolerability. Stomatitis occurred in almost all patients. It was grade 3 in 20 to 40% of them. Patients did not receive prophylactic mouthwashes, but it's important to incorporate mitigation strategies to these adverse events as the combination moves forward. Rash was also very common, with a high proportion of grade 3 rash in cohorts A and B. In contrast, in arms C and D, rash occurred in less than 10% of patients, so I wonder if any prophylactic treatment was used in these arms. While discontinuation rates were low, it is important also to discuss the rates of dose interruption and reduction. Clinical activity of gedatolisib, palbociclib, and letrozole in first line was impressive. PFS of 31 months, overall response rate of 85%, and the clinical benefit rate of 96%. Now let's take a minute looking at the results for patients progressing to prior CDK4/6 inhibitors. Median PFS was 5.1 months in arm C and 12.9 months in arm D. Overall response rate was also different between the arms, 32% in arm C and 63% in arm D. Of course, these are small numbers, but these differences in efficacy deserve more discussion. So do they have a biological basis, or is it just related to patients' characteristics as highlighted previously? Also, was the dose intensity different between the cohorts, and this may explain these differences? So to answer some of these questions, the authors explored the outcomes according to the duration of the immediate prior therapy. Patients with primary resistance to prior therapy had longer duration of study treatment in arm D, 9 versus 2.7 months, and also higher response rate. Actually, there were no responses in arm C, while the response rate was 71% in arm D, suggesting that gedatolisib's schedule may impact on the efficacy of the triplets. Now, given these results, I wonder which is the dose that will be chosen to move forward, and also which is the context of the planned phase 3 study with gedatolisib, palbociclib, and endocrine therapy. Finally, I wonder if there are some biomarker analysis planned here, specifically if there is some differential activity from gedatolisib in patients with tumors with PIK3CA or other pathway mutations. So in the last abstract in this first group, Dr. Hurwitz and colleagues report the final results of Trinity-1, which tests another triplet, ribociclib, everolimus, and dexamethasone in postmenopausal women with HR-positive, HER2-negative advanced breast cancer after progression on a CDK4/6 inhibitor. 2 dose schedules were used, and note the reduced doses of both ribociclib and everolimus which were tested due to the known drug-drug interaction between the 2 drugs. Today, the authors present the efficacy and safety results for phase 2 and the biomarker results for phase 1 and phase 2. Objective response rate in Trinity-1 was 6.5 and 9.4% in both groups, and median PFS ranged from 4.7 to 8 months. But please note the difference in PFS according to the time on prior CDK4/6 inhibitors. In the biomarker analysis using ctDNA, the presence of a ESR1 or a PIK3CA mutation associated with numerically shorter PFS. I wonder also if there are any plans to look at additional biomarkers of response to this triplet to find a predictive biomarker to ribociclib, everolimus, and dexamethasone. Common adverse events in Trinity-1 were stomatitis, neutropenia, fatigue, nausea, and thrombocytopenia. These patients were given prophylactic mouthwashes, and note the very low rates of grade 3 stomatitis in Trinity-1. The rate of infections, in contrast, was high, and I wonder which were the most common infections and if these were related to neutropenia or lymphopenia associated with ribociclib and everolimus. The final question to discuss here would be the impact of the adverse event profile in the dose intensity these patients received. Now, this table summarizes the efficacy results from some of the trials testing triplets with endocrine therapy, CDK4/6 inhibitors, and PI3K pathway inhibitors. While results of the sum of the combinations are really interesting, tolerability may be the pitfall for this triplet, and it must be carefully balanced against the potential PFS benefits. My final question for the authors of Trinity-1 is, what are the future plans of this triplet and how they envision this combination in the current landscape of treatment in advanced ER-positive, HER2-negative metastatic breast cancer? Now let's move to the second group of abstracts. Dr. Iwata and colleagues report the results of the NEOS trial, which addresses the question of whether adjuvant chemotherapy provides survival benefit in patients that responded to neoadjuvant endocrine therapy. This is a clinically relevant question. Postmenopausal patients with no negative tumors up to 5 centimeters were enrolled and received letrozole for 6 to 7 months. Those who had a response or stable disease underwent surgery. Note that 171 patients were excluded from the posterior randomization because they had 4 or more nodes involved with surgery. The remaining patients were then randomized to receive chemotherapy plus endocrine therapy or endocrine therapy alone. Just 2.4% of patients in the chemotherapy arm received the standard anthracycline plus taxane regimen, and 20% of the patients that were randomized to receive chemotherapy did not never received it at all. Most patients had T2 tumors. Around 20% had 1 to 3 nodes involved with surgery, but some data are missing regarding the axillary surgery for patients randomized to endocrine therapy alone, and this will be important in the discussion of the results. Now, estimation of 8-year disease-free survival was 82.7% in the letrozole arm and 85.6% in the chemo plus endocrine therapy arm, with a non-statistically p-value of 0.1262. The differences were mainly due to local regional relapses, but it should be noted that only 101 from the initial 170 events were registered, and for this reason, the study was actually underpowered to detect a true difference between the groups. Distant disease-free survival and overall survival were also similar. So it would be interesting to know some additional data for the correct interpretation of the NEOS trial. First, it would be nice that the authors could complete the analysis on Oncotype DS that they reported back in 2018 with all the data sets of the patients enrolled in NEOS. Second, it would be important to know 2 important parameters that correlate with long-term outcomes in patients undergoing neoadjuvant endocrine therapy, like on-treatment Ki-67 and PEPI-scored surgery. And finally, it's important to understand what were the patterns for radiotherapy use and the axillary management in the endocrine therapy alone group. So the last abstract from Dr. Sell and colleagues focuses on the use of extended adjuvant endocrine therapy in a longitudinal cohort of young women with early breast cancer. The authors launched a survey in the context of the Young Women's Breast Cancer Study to assess the use of extended adjuvant endocrine therapy in premenopausal patients with stage 1 to 3 tumors, HR positive, and who had diagnosis 6 or more years after the initial diagnosis. From the 663 candidates for extended endocrine therapy use, 490 returned 1 or more surveys and were included in the analysis. Women that returned the surveys were most likely to be non-Hispanic white, financially comfortable, had a college or above education, children pre-diagnosis, and received chemotherapy. So in univariate analysis, patients who were not receiving extended endocrine therapy were younger, white, non-Hispanic, not married at baseline, with no children, had stage 1 tumors, and did not receive chemotherapy for their disease. In multivariate analysis, only age, race, stage, and chemotherapy associated with extended endocrine therapy use. These results seem to reflect adequate care, but of course, we must be extremely cautious in analyzing the data coming from self-reporting. Now, the use of extended endocrine therapy decreased over time. Tamoxifen monotherapy was the most common approach. AI plus OFS was only reported by 6.8% of patients, and the use of AI plus or minus ovarian function suppression increased over time, although there was no change on the use of extended endocrine therapy overall. And interestingly, the difference in extended endocrine therapy use did not seem to correlate with side effects that were experienced by these patients in the first 5 years of endocrine therapy. So I think that authors should be commended for looking at this important question, given the scarcity of data regarding this issue that has to be addressed, in my opinion, in prospective clinical trials, as it seems that some disparities exist regarding the use of extended endocrine therapy among young women. It would also be important to prospectively study this issue. So I'd like to stop here and thank the authors for having sent me the poster and slides in a timely manner, my team at VHIO, and also the member of SOTI Board of Directors, and especially Cristina Saura, Meritxell Bellet, and Guillermo Villacampa for their thoughtful input, and all of you for your attention. Thank you.